First of all, thanks, Partha, for your wonderful presentation. And you are always a very motivator. And I have a few disclaimers before I start this debate. We are deeply patriotic and proud Indians. We hold immense respect and faith in our government and healthcare system, and which serves a large population, 1.4 billion. I am honored to serve as a board member of our national program for prevention and control of cancer, diabetes, cardiovascular disease, and stroke, and particularly in a national health policy for type 1 diabetes care under Government of India, Ministry of Health and Planning Commission. Dr. Partha, my close friend, and he is known for pushing equity for access. We Indians are proud of your work, what you are doing for UK and what you are doing for India. That's very important disclosure. And the debate is designed to understand type 1 diabetes gaps in India. So we are primarily, it's not for UK health policies overall, it's primarily for type 1 diabetes gaps in India and talk on future solution. We know that from 2017 we are meeting, first time I met him in diabetes UK meeting, and then we were there in US, and then we planned type 1 diabetes conclave and many more things. And since last 7-8 years, we are working very together. I deeply value the contribution of healthcare professionals, advocates in type 1 diabetes field, and my perspective comes from my clinical experience and observation which we have done in last 15 years. So we have done a lot of changes, but what we are saying that it's not so easy. Implementing NHS like healthcare policy in India would be a cakewalk. Anything that helps to type 1 diabetes care, I will never say no. I will never say, I will be always on a positive side. I wanted to happen this change. But here I will use this NO as a new opportunity or not possible. Because these are the new opportunity which I can learn, I can work with Partha, and I will be definitely very happy to part of this new opportunity which we are going to have. My agenda will be trying to understand the India and its diversity, healthcare system in India, the differences in India and UK, and then there are some hidden truths of India too. This is a population of 1.4 billion, and we have 50% of the population which is poor, which holds 2% of the wealth, and that's what we have to feed them. Middle class is the 40% of the population, which is around 11.6 to 23% of the wealth, and we have upper class, and that's what we are saying, that we can afford everything. And I always say that those who are upper class, please make sure they get the best of the best treatment, because they are going to change the lower class tomorrow. That's what we want for us. So disease burden, we have dual burden, and that's very important because we have a challenge of infections and chronic disease, and I'm sure UK also have many challenges like what cancer care, and the same way we have the challenges of infection too. This is what I told you, the poverty, 50% of population in need, they need for food security bill is there, and they are given free food. So forget about getting money from them. If you are asking for them the best therapy, the next question will be, what about my evening food? That's what we have the challenges. The healthcare system is also, we have primary care to tertiary care, and this is the public health system. This is from primary healthcare center, community, sub-district hospital, district hospital, and medical college. We have primary care to tertiary level, and Indian healthcare system is focused on system built to tackle communicable disease. So our system is to build, extinguish fire, not to maintain furnaces. And that's very truth of India at present. If I go to medical college, you'll be surprised. There is no dedicated type 1 clinic, even in the endocrine department across the country. More than 50 tertiary care hospital in India are having a DM endocrine program, but they don't have dedicated type 1 clinic. And that's what the truth is. Chronic lifelong condition like type 1 diabetes as less integrated in a public health. That's again important aspect. Public health and PSC are structured for one-time medical response, not for chronic conditions. Most government health programs are focused on a high mortality and a high incidence illness. And that's what our government focus is. Like tomorrow if you go and talk to them, they will be talking about the malnutrition, diarrhea, pneumonia. These are the common problems they have. We have huge ecosystem. Even trained endocrinologists are prescribing non-specific prescription, and this is truth. I'm going to show you one of the prescription, but this is not because even there is no dedicated type 1 clinic. They just want to prescribe therapy, nobody is going to review them. And we have all other alternative systems also, which are equally popular in our country, which is Ayurveda, Yoga, Unani, everything, which are also practicing allopathy without even any permission. This is one of the prescription by a trained endocrinologist. I am seeing you in 29 July. This guy is at 25 years with a 10 years of diabetes. Even he might not have done any investigation for this person to confirm the diagnosis of type 1. But can you think of someone with a weight of 43.75 kg with a 10 years of diabetes history, with a 45 kg man in a 25-year-old person, has to be type 1. And this is what the prescription is showing, 30/70 by a trained endocrinologist, with a glimepiride, which is a glimepiride, with a telnipiride, and with voglibose. You can see here all other anti-diabetic medication. Now the point is, if someone like a trained person writing this prescription, what will write the primary care physician? They have to learn from these people, and they will be writing again and again the same prescription. Let's take a closer look difference between India and United Kingdom. We have a large population. I need not to talk that. We know that India can be compared, or the West Bengal can be compared with UK. But this is what the GDP, India, and per person GDP is what you can see. Nominal terms, UK per capita income is 20 times higher than India's. And if I just take the inflation part, the adjusting cost of living, UK still leads by 5 times. And that's what the GDP or a per person, it's like 5 times more than that. India government is spending on health is less, both in absolute and relative terms. UK by contrast has a tax funded NHS. I always say, someone asked me that why in India government is not providing free pump to anybody. We had gone, India can provide now, when we can have 1 bullet train, now 10 bullet trains we are going to have. And 1 bullet train is costing more than 2 lakh crore, which is going to cost for 1 bullet train, and we are going to have another 10 in next 5 years. With 1 bullet train, the cost, we can provide everyone, all type 1 in India, the best of the best therapy. So not possible, is it? But only thing is the government has to do it. The total health expenditure is only 3 to 3.3%. By public funding is 1 to 1.4%, with per capita spending nearly only $74. While UK, this is 10% of their GDP, with public funding is 8.7%. And per capita spend is $3,500. So you can compare US 74 versus 3,500. That's what we have. The financing gap is UK healthcare is spending 9, while India healthcare is spending 1.9. And this dramatic difference in healthcare funding creates a fundamental constraint on what policy can realistically be implemented regardless of that design. So whatever I design, we have to go to the public place and we have to ask them to make the policy, and they will say that we don't have that much budget. This is what the UK priority. They have cancer, cardiovascular disease, and diabetes, while India reality is still, we are struggling for tuberculosis-free India. We are struggling, we want that malaria, dengue, diarrhea, rabies, other infections, malnutrition, and we are midday meal program are one of the biggest, for the children. We are providing them midday meal. We are not providing them insulin, but we are providing them midday meal because they don't have, neither they take breakfast nor they can have afford to go and have dinner also. These are some of the hidden truths. We have Ayushman Bharat, one of the biggest, I can say even bigger than any other or UK health policy. This Ayushman Bharat, Pradhan Mantri Jan Arogya Yojana, is a landmark health insurance. So everybody in India with 500,000 rupees, they are insured, and they can be providing free tertiary care, not only in the government setup, they can go in even in a private setup. The surgery, you cannot think of even in UK to get someone angiography, bypass, angioplasty, knee replacement, stroke management, everything is free up to that money. But the problem when it comes, what they are saying, for any acute problem, we are ready to pay. For any chronic system management, we don't have the system. And that's what the biggest challenge is. It's not that India government is not looking for it, and we are talking to them multiple times. Since last, he knows that, and he is part of many of our meetings, and this is what we are doing. Ayushman Bharat, why it is? Because they are thinking it's a chronic care basis. I think India is not geared up. We are still for the acute problem. Visibility of impact, we have policy gaps, supply chain, limited awareness. This is what the ICMR guideline. And I was the only one who stood against all those people who become part of the ICMR guideline. They had asked me to become the part of ICMR guideline for type type 1 diabetes? I told no, because they asked only 2 times is sugar to be checked in a person with type 1 diabetes. This is the national government guideline. I told I will not be the part of it. This cannot be. How it is possible that you ask from the government of India, ICMR is making the guideline for a type 1 only to get 2 times the sugar. For the guideline, they have to check at least 5 times, 6 times, 4 times. How they can have that sort of a ICMR guideline? The private-public partnership is yes. We private doctors, when we go to the public hospital or when we wanted to go and government talk, health department, finances, hospital administration, this is what each state, it is like each state is responsible for their health. It is not the nationally we can think of making policy, but still, like in Kolkata, my good friend Sujoy had done, we are struggling. I could convince health minister, we have the budget which is already allocated, 11 crore per annum from last 3 years. And this is what we are meeting with health minister, we are meeting with health commissioner in Gujarat. They have the money, but they don't know what to do. Because one thing is, Dr. Sujoy is working with a government hospital, he's a professor. And when they see me, I am a private practitioner. They have first thing they will be asking, why you are so much interested to improve the public hospital care? Why you are interested for that? And still efforts continue. These are the pediatric disorder. And when I go and invite the people from professor of pediatric, a private pediatrician, a pediatric endocrinologist, a pediatric neurologist, a neurologist will come and say that, see, these many people have epilepsy. What you are doing for them? What about the neurodevelopment delay, which is much more than type 1 diabetes? Psychiatric disorder in pediatric age, disabilities. These are the absolute number in India with 3 million. I have less than 200,000 people who are actually type 1 in India with the incidence, and 3 million children have absolute disability. What we have, pediatric disorder. Prevalence comparison always show this is a low population disease. Policymaker focus on disorder which higher prevalence, and shifting the national focus or budget significantly for type 1 diabetes may seem disproportionate to public health planners. These are the other challenges. We have multiple stakeholders. I talked about a Rashtriya Yojana, the next, but there is a Rashtriya Bal Swasthya Karyakram. Even that 11 crore rupees had gone to Rashtriya Bal Swasthya Karyakram of Gujarat instead of giving it for type 1, which health minister announced it. Still evolving health technology assessment ecosystem. This we are producing a paper with the Public Health Foundation of India and talking that this is what the HTA is. That if you are going to give the technology to these people, I am sure they will have a better quality of life, a longer life, and they will make the changes. This is what we are doing. The dilemma is for children and families with type 1, lifelong burden is immense and unique, but national priorities are guided by immediate population level impact. The government is looking that what is the immediate impact is there. They are politicians, they are looking for their votes. What can be changed for that? That requires careful advocacy to alleviate chronic illness without minimizing broader system challenges. Advocacy, there are multiple gaps. I don't go and ask the government now provide 4 times insulin. That they are already getting. I go and ask them to provide the CGM. I go and ask them to get the best of the best system AID. Why can't we have the best system in India? And that's what available is at least. And all the private practitioners, all pediatricians, anywhere if I go and I talk about the best therapy which is available. But there is a lack of public insurance coverage for diabetes technology. So implementing UK like type 1 diabetes policy in India is not a cakewalk. It's rather a cake fall, because our children deserve a policy which is backed for India, not imported from London. That is what we feel. The way forward is goal. Ensure a very equitable, accessible, and a very high quality care for all children and adults with type 1 diabetes in our country. We have come a long way in type 1 diabetes. What gives us the hope? So I don't say that we have not come in a long way. As Partha had already said that from 2008 I am working. I was when part of advisory council for SPAD. They were surprised that why you are here. You are an adult physician. What you are doing for type 1? And then I asked, no, I want a meeting in SPAD. The first time SPAD never had gone to any developing countries. It was only in India in 2018. And we changed the scenario in India. Till that picture abhi baki hai mere dost. Our type 1 diabetes care in India will definitely improve. We need your help. We need your all the time your support, and still story is still unfolding. Integration with ABHA and healthcare program. This will help build a lifetime care system and prevent children from being lost in the system. This is what the ABHA program, which is launched by Government of India. It is like each and every child data when you put it, even for the private practitioner, they pay from the ABHA, the Government of India. Community health worker empowerment, mobile support. We have our own WhatsApp chatbot, multiple languages. Our Type 1 foundations, they are working very hard, low cost. A tech-enabled last mile ecosystem, so no child with type 1 diabetes left behind. That is what our vision is. We are looking for a national type 1 diabetes registry, integrating type 1 in existing health programs in states, financial and insurance integration, foster research and invest in health technology, and implementing school and community-based technological solution. So let us say no, it's not, it's new opportunity. I'm not here debating against Partha. Partha is part of our system. He is what we have to work together. That's what we are looking for. We want new opportunity to improve the care for type 1 in our country, opportunity to innovate, integrate and inspire, opportunities to ensure that every child with type 1 diabetes in India has same right to life, health and hope as anywhere else in the world, maybe UK or even any Western world, US or Canada, anywhere. So India must design its own type 1 diabetes policy. The recipe, affordable, inclusive, digital first, not copy paste from any, whether it's a NHS or, as already Partha said, that's not great. We are looking for our own. Implementing UK-like health policies in India is not a cakewalk. It's like a trying and wearing someone else's tailored suit. It may look elegant because it's UK, but it won't fit. India needs its own design, its own fabric, stitched for its own people. India is also the land of frugal innovation, digital revolution, and resilient families. With this, love the phrase of Dr. Partha, roses are red, violets are blue, till then supports will do. My version is roses may be red, violets blue, but until the system grows through and through, smart support, local care and compassion will do. Jai Hind. Thank you very much.